launching a visa because we have a
I
talk
see.
in our next
So you're
week
live.
conference.
Akash, we are live
Yeah,
now.
I might speak with Makkar then. We'll see.
Okay, so let's begin. Good evening, everybody. Thank you so much for joining in on a Sunday. I know it's a weekend and all of you have taken time out to be with us. So thank you so much for that. Today is the last day for learnings from ADA session. So this has been a 10-day long session. Extremely good response from various participants. We have nearly 9,000 registrations so far. So which is already a great success for this program. It has achieved the primary intent of it. The whole idea of this was created in order to help all those medical professionals who were unable to be physically present during the ADA Act that was held in the US, and to help them benefit and to understand or take back learnings from that is why this was organized. Various experts who delivered talks or who were present in those sessions have agreed kindly to speak with many of our audiences. So as we already know, nearly 9,000 registrations. So which is a great thing. So I think this is opened grandly, the first time that we've done learnings from ADA. So we've opened grandly and today is the last day. I'm going to start sharing my screen to take everybody through a little bit of what information we have. So let me know when you can see my screen.
Yeah, we can see.
Yes. So let's start with an introduction. Diabetes India 2025 is coming up in February. So please go in and register for this. Be early birds for this massive conference. Enroll yourselves. Benefit from attending this. So that's where we start with. And then we would like to, since today is the last day again, we'd like to thank many of our key contributors, Dr. Azad Khan, Dr. S.R. Arvind, and Dr. Bansi Sabu, who have been instrumental in mobilizing this whole thing, in putting it in place and planning the whole conference. So thank you to all these people for doing it. Definitely not without the support of as well, Dr. Sanjay Reddy and Dr. Amit Gupta. So thank you to them. It's my privilege to introduce the moderator for this session today, Dr. Akash Singh. He's a senior consultant based out of Vadodara in Gujarat. So sir is also the president of Indian Diabetes and Cardiometabolic Diseases Association. He's an executive body member in the Association of Physicians of Gujarat. He's the vice president in the Association of Physicians of Vadodara, which is a government and of the governing body master, West Zone CCDSI. So sir, welcome to you and over to you.
Thank you very much. So today we'll be listening to some of the sessions from ADA 2024 held in Orlando. And the first talk would be delivered by Dr. Rakesh Parikh, which is on AI tools which will change the diabetes practice in future. Dr. Rakesh Parikh is a well-known speaker, is a fellow of American College of Endocrinology, Royal College of Physicians and Surgeons, member of National Executive RSSGI, founder Metabolic Society, Jaipur, recipient of several awards. He is a well-known speaker and a well-known researcher, and he has published in majority of the national and international journals. So he is a well-known figure. Nothing more to introduce. And this year we had a session on the role of AI, increasing the role of AI in the management of diabetes practice, which included detection and prediction of events, classification and tracking of disease progression, AI powering decision support systems, AI driven neural network automated insulin delivery, AI augmented clinical trials, which have a most promising future. And all of these basically predict that AI will come a major way in management of diabetes in future. And to listen to this, we first have Dr. Rakesh Parikh with us. Dr. Rakesh Parikh, please proceed.
Thank you, Dr. Akash Singh, sir, for such a wonderful introduction. I think I'll just share my slides and then maybe we can start with it. I'll give you 1 second for that. Uma, do I have the rights for sharing the slides? Let me check.
Yes, sir.
Okay. Wrong PPT. Sorry, I'm taking a minute because I'm trying to find my latest file. So I think now my entire desktop is visible, right?
Right.
Yes.
Will that work? Let me check. Okay, so I think now we have the right slides.
Absolutely.
But that was the last slide, so let me start with the first one then. Okay, so apologies for the delay. Now today I'm supposed to talk on how will AI change the diabetes clinical practice, and that's a very vast topic. So I'll have to rush through a lot of slides. I'll just give a glimpse of the different things that are happening today. I also have some slides on how you can use the Chat GPT. How can you make your own custom GPT and use it for some routine work at your clinic? So I'll try to include those if the time permits to me. So let me start with this slide, which shows the opinion of two, big leaders from the business field. One is Sundar Pichai, who is the CEO of Google, and he says that probably AI is the most important thing to happen to mankind, probably more important than even the invention of fire and electricity. Whereas on the other side, Elon Musk feels that with artificial intelligence, we are summoning the demon. So these are the two contrasting views that people have, and the debate is still on. Now, to just introduce the subject, AI basically is a broad term where anywhere where you give some kind of intelligence to a machine, that's called AI. So that is not something new. It has been there for decades. So the calculators that we started using since our early days, those also had some kind of AI. And later on, there were some improvements. In last few years, we had some tools like the Siri and then Alexa. They all have the AI capabilities. And they also have the machine learning capabilities. So machine learning is basically a subset of AI where the machine starts learning from the data that it has. And then there is a deep learning. So deep learning is again a subset of machine learning in which there are deep neural networks which are involved. So this deep learning is utilized for some particular difficult tasks. Before that, machine learning can be either supervised learning where a supervisor provides the data to the machine and a label to the data, and then the machine learns from that. Or it can be unsupervised where the machine itself makes the clusters of data points which are similar to each other, and then it makes its own algorithm. The deep learning, as I said, it's a little more complex advancement in the AI, and the applications are in the form of computer vision. So what does computer vision mean? It means the ability of the computer to read an image, read a video, or understand an audio file. So that capabilities the computers now have. That is because of the deep learning. And then there is natural language. So natural language is the ability to understand the natural language that is called natural language models. So that is what is new, which has happened recently in the last few years. And the sudden hike is because of the generative AI. So as of now, we were just talking about the computers doing some intellectual work or analyzing some data for us. But now the computers can generate for you. So with the generative AI, the most popular one among us is the Chat GPT. The Chat GPT can generate a new content based on the requirements that you have. And that is why it is suddenly being spoken a lot about. So now coming back to the generative AI, there are different applications of generative AI. There are different models. And among those, the popular ones are ChatGPT and Gemini. So we'll talk about ChatGPT in the later slides. Before that, I'll talk specifically about the applications of AI in the field of diabetes. So currently, there are limited applications of diabetes, of AI in the field of diabetes, largely for automatic retinal screening, which we have been doing since last few years. Now we have the AI-enabled fundus cameras. And then there are clinical decision support systems. So there are some systems which have been approved by FDA as a product. And these are all AI-based models. Then AI is now also being used for risk stratification. And also there are several self-management tools for diabetic patients, which are also based on AI. So this is the basic principle how the deep learning or the computer vision works, and how the computer can read the fundus images for us. So initially, the fundus photographs are provided, and the deep learning model starts analyzing those photographs based on the data that has been given to it, and it will make some analysis, or some output will be there, or some results will be there that will be compared with the actual report, and there will be some difference, and that will be the feedback to the computer. Then the second image, it will do the same process. So once it goes through this process for 100, 200, 300 times, it becomes expert. And that is how the fundus cameras that we use nowadays, they are able to tell you whether the fundus is normal or not normal, where the lesions are those background retinopathy changes, or those are advanced stage changes. So these are all things which are possible because of this. Now, the clinical decision support system is the another area where AI is being used. So basically, there is a lot of raw data which is coming from different wearable devices and the devices that the patients use for their monitoring or for treatment, like the CGM, SMBG, insulin pumps, insulin pens, the smart pens, then activity trackers, and so many other wearable devices. The whole data goes to the algorithm, which is the machine learning algorithm, and the algorithm then uses its own logic, and it gives us the output in the form of prediction for hypoglycemia in the next 2 hours, prediction of hypoglycemia in the next 4 hours, or the risk of hypoglycemia in the next night, the overnight risk of hypoglycemia, and so many other things. So this is the kind of clinical decision support system, and one of those is the Diamed, which is a FDA approved product. So this is basically again only AI based product, but this product again takes the inputs from the patient's CGM device, the insulin pump, and then it uses its own algorithms. It also considers the other parameters and then based on that, it decides the dose of insulin, the corrections in the basal dose adjustment, or the bolus doses or correction doses, whatever is required. That is done by the algorithm itself. And then this has been tested via trial. So this trial, in this trial, they have, I think the slide is there. No, sorry. So there was a trial in which they have shown that if you use these algorithms, which are based on purely machine learning models, the models can do equally good as a qualified endocrinologist. And that is how this product also got FDA approval for a decision support system for patients who are on insulin pumps. Now, the closed loop systems that are available currently, they all use the some or other form of AI algorithm through which the algorithm itself decides the dose of insulin based on the glucose reading that is being received by the algorithm. I'll run a little fast because I don't have much of time and there's a lot of slides to cover. So bionic pancreas is something which is now coming up, and it's a new thing. You don't require to give any inputs to this particular pump, and this is insulin pump basically. So you just need to feed your body weight, and after putting the body weight, the machine starts adjusting the dose of basal insulin itself, and then it learns, and you just need to announce your meals. You don't need to mention the doses of bolus that you want to give. Just announce the meal that I'm taking a breakfast, whether it's the normal usual breakfast, it's a high carb or low carb, and then it decides the dose of bolus also. And this pump has also been shown to work very well for the patients of diabetes. Then there are several crazy studies or papers that have come up. So if you look at the parameters or data that AI can use for making predictions, it sounds very crazy. So this was a study in which they just gave the facial photographs of some subjects, and based on some facial features, the AI algorithm was able to predict whether the person is diabetic or not to the precision of something around 0.92. So that is highly precise prediction. So this was a study which was published based on that. Then there's another study in which they looked at the prediction of new onset diabetes among patients who are hospitalized, or there are some other studies also. And in all these studies, you can see the number of the sample size is huge, and the algorithms were able to predict the development of diabetes over the next 5 years without using the glycemic parameters as the input. So they relied on the other parameters which might be able to help the algorithm the prediction of diabetes. Then clustering also, we are aware that nowadays the classification of diabetes is changing based on the clustering of factors which are there in different groups of patients. I'll run a little fast. So AI is also used for diabetes education. The AI models can educate the patients, and they also shown to improve the HbA1c of the patients without any interference from the doctor's side. It can also be used for carb counting. So just take a photograph of your meal, and the AI will count the carbohydrates in that plate. It can be used for giving the individualized medical nutrition therapy or the diet charts to the patients, and again that has been shown to work very well. So these are several applications of AI just in terms of healthy eating, and all these can be in the near future we can all have these as different tools. Then personalized physical exercise advice also can be given by the AI models, and there are some studies on that also. Blood glucose prediction can be made based on the patient's doses, activity, diet, and all those things. The model itself can predict the blood sugar levels in the next few hours. Then for optimal insulin dosing, again you can use the app where the app will tell you what is the dose to be given. And this has been tried in a trial, which was a randomized control trial, and it was shown that if a SCP uses this app, it does better than the SCPs doing their own, using their own logic. So the results were better. It can be also used for the optimal OAD to choose for a particular patient of type 2. It can be used for the dose escalation of the OADs. It can also be used for predicting the complications of diabetes. So these are all the things which are coming up in the future. This is a multispectral wound imaging camera, which is again AI based. You take the photograph of a diabetic foot, and based on that thermal images, the software tells you whether the patient is having a gram-positive infection or gram-negative infection. And that's again highly accurate to the tune of 90-95%, and that can help you in choosing the antibiotic for that particular patient. So this is again a study based on that. So I'll just take 2 more minutes because my time is over, and I'll talk a little bit about the ChatGPT. Now, ChatGPT is something that anybody can use. It's freely available. If you use a free version, you can use the ChatGPT 4.0 for a limited period of time. But if you want to use it unlimited time, then you can go for a pro version of this. So the good thing about ChatGPT that I like most is the custom GPTs. So once you log in, you can go to the Explore GPT option, and there you can search for different GPTs which are already prepared, which might be useful for your own practice, or you can create own GPT of yours depending on your requirements. So if you click on this create button, you can actually create your own GPT the way you like it. On the left side, you see a window. So here you just need to give the inputs that what do you want the GPT to do. You can tell them that I want a GPT which works as a assistant for a diabetologist and helps the diabetologist in different activities or different responsibilities. So this was one custom GPT that I designed or configured. That's Diabetes Clinic Assistant. And then these are the different modules that I gave it. So this can be used for looking up for any medical term that you may not be familiar with. It can be used for calculators or different calculators that you use in the clinics. It can also be used for clinical diagnosis. So if you are doubtful about a particular case, just put the history here, and the GPT will give you the diagnosis, which is most likely, along with the reasoning also. It can also interpret lab reports. So if you give a PDF file, which is a 50-page report, and ask it to just pull out the abnormal findings, it will pull out the abnormal findings. It can analyze the images, which are medical images. It can also provide you individualized diet charts, which can be in the regional language. Those can be customized based on the cuisine that they are using: North Indian, South Indian, vegetarian, non-vegetarian. All these things are possible. I'll go on with the slides till Dr. Akash interrupts me, because I think I have 1 or 2 minutes more. So these are the menu items. I use it for medical dictionary. It gives results like this. I use it for scoring. So I just had to enter, if I want the target height, I just enter 3, and then it will ask me father's height, mother's height. So if you can see the inputs here, I just mentioned 176, 168. It understands that 176 centimeter is the height for father and the other one is for mother. It gives you the target height of the patient. I tried it for a case. So I just posted a case, and then it gave me the possible diagnosis and the future advice how to work up for this patient. I uploaded a PDF file of reports. It came up with the findings which were clinically relevant. So this was the image of diabetic dermopathy. Just wanted to test it. So I uploaded the image, and the GPT came up with the diagnosis that it's a diabetic dermopathy. I also tried this image of a dry gangrene. Again, it came up with the possible diagnosis as gangrene. Uh, Again, this was Shako food, so that also it worked very well. And then I asked it to create a diet chart in Hindi for a South Indian, a vegetarian. So it made the diet chart also like this. And this takes just hardly 30-40 seconds for the GPT to work. So this was a chat that I got today in the workshop. Today I had a workshop in Pune on AI. So one of the doctors gave me this particular image, which was a SMB chart the patient had made. I just uploaded that to the GPT. It converted it to table. And then I asked it to make a graph out of that. It gave a graph like this, which is not similar to AGP graph. Of course, there are limited readings here. I asked it to convert it to something like a AGP, and it also could convert that. So if you have more points, it will give a better AGP graph also based on this. So this particular diabetes clinic assistant, you can scan this QR code and you can use that, try to use it in your own practice. So I'll just have 2 more slides and I'll end it. So what is the future? Now, ChatGPT 4o basically has audio and visual capacities also. So the app on the mobile can see through its camera and read your facial expressions. It can talk to you in real time. It can answer you your queries like a real human being. We also have seen that there are AI avatars of people and they interact with the real person. So in the future, maybe you can have the avatars of Dr. Rajaram Karne or Dr. Akash Singh doing most of their jobs. The avatars might be having the whole knowledge set that they have, and they can do their job maybe under their own supervision only. And then this was the news a few months back that China is the country to have the first AI-based hospital. So this hospital has the health agents which are AI-based. So I don't know what the future is, but what Stephen Hawking said, I don't know, I missed that slide, I think. Yeah, this was a slide. So Stephen Hawking said long back that probably the development of full artificial intelligence could spell the end of human race. So let's be hopeful that we make the best use of AI and it doesn't overtake us. So I'll end my presentation here with the last slide, which is about the conference that we are doing in Jaipur. Sorry, this QR code is not working now. So we are doing a conference in Jaipur. That's a DTechCon. And those of you who are interested in AI and other technologies can join that conference. Thank you very much. And sorry for overshooting my time.
Thank you very much, Rakesh. This was an excellent talk, well deliberated and precisely delivered. I just ask Ms. Uma to play some videos which she has before we commence the next talks.
Thank you, sir. So today's sponsor, so we've had a sponsor for each day that we've been conducting these sessions. Today's sponsors are Torrent and Sinocare. So this day came about because of their support. So a big thanks to them. So we now play one of their videos. Can I ask the tech team to start that? Thank you. Sir, back to you. I will share the CV.
I welcome Dr. Rajaram Karne for the next talk. He is a diabetes and diabetic physician, Belgaum Diabetes Center and Centra Care Institute of Diabetes, Obesity and Metabolic Health. Medical Director, Centra Care Super Specialty.
I think that's not my information, so
Yeah,
I'll
that's
just
not
introduce
true.
myself.
Uma, there's some
Sorry.
mistake here.
I was also
Not in
surprised.
Belgium. Yeah. Sorry,
Right.
I'll just give some short information. I actually did my med school, medicine and endocrinology in India in KEM. Then I moved to US. I did my residency and fellowship again here at National Institutes of Health. And then went to the faculty of a university in Ohio State. Then I practiced my own office, and now I work with the Department of Veterans Affairs. So old friend of all my Indian colleagues, including Rakesh and Shashank Doshi and many others. So thank you so much. Can I go ahead with my talk?
Definitely, sir.
Let me share my screen.
Yeah, proceed.
So first of all, congratulations on the Diabetes India for creating this particular program. It has been a wonderful conference. It was infinite things to learn in 4 days, and getting it back to India was a phenomenal concept. So congratulations, Bansi and the team. And also thank you so much for letting me speak on this one. As Dr. Rakesh Parikh put it eloquently, that AI is going to be a major part of our future. The conference itself was heavily technology driven. So insulin by itself was a smaller part of the whole conference because there was not much development within insulin, but there was a lot improvement in the how we deliver it. So these are the highlights of conference, with technology taking the lead with artificial intelligence, continuous glucose monitor, and closed loop, which is also called automated insulin delivery. And a huge chunk of the conference was taken by the GLP-1 analogs and GIP-GLP dual analogs, with their benefits with not just diabetes, but with the heart. And now liver has been the major center for cardiometabolic or diabetes and metabolism. SGL2 inhibitors, again, were seen to benefit the heart and kidneys, and newer data came. So basically, whole conference was related to that. When it came to the insulin, again, as I said, different delivery methods, AID, and then SAP is a term for sensor augmented pump, in which the patient has a CGM, but the information or the dose that is entered in the pump is manual, and then multiple daily insulin techniques. In terms of the newer insulin, the only highlight was a full lecture on inhaled insulin, which is branded as Afreeza here. And then there was a glimpse, short reference to the once a week insulin. So today's talk is going to be completely on mostly on inhaled insulin. So basically, it starts with the technosphere, which is a microparticle, and then we attach the regular insulin to that. So this is still a regular insulin, not the aspart or the Humalog. And then at pH of less than 6, it becomes an insulin adsorbate particle, which is stable at lower pH. But when it is inhaled, the physiological pH is higher than 6. And at that time, the particle dissolves quickly, and both the particle and the insulin are quickly absorbed. So this actually is much more rapid insulin than Lispro. Now, Lispro is considered as RAA, rapidly acting insulin, but still, if you see, its peak concentration of Lispro comes at about 45 to 60 minutes, while Technosphere, we call it the TI now, Technosphere insulin, it will peak in 12 to 15 minutes. And the downside, it will go out of your system also very quickly. So rapid in, rapid out, and it has a lot of implications in actual treatment. It has a very strange unit concentration. It comes as 4, 8, and 12. The machine is very small. I mean, any of you remember Exubera was made by the Pfizer, and it was a big, long bong. Compared to that, this one is a very small. If you look at the hand of that person, it can be carried very easily and taken very quickly. It's very compact. There have been a lot of trials. Actually, first time the inhaled insulin was introduced in 1997, and there have been continuous development about it. The last one, which is Inhale 3, that's what was discussed at the ADA, and I'm strictly limiting to what was discussed at ADA. So this trial data has been published for the first time at ADA. So that's Inhale 3, which is they had inhaled insulin along with degludec. Now remember, these are the type 1 diabetics, so they have to have a long-acting insulin. And the short-acting insulin part was only replaced by inhaled insulin. And that was compared with the people who had either pump with a different automation and multiple daily insulins. Just one disclaimer here that this data has not been published yet, so it is still the property of mankind. I am sharing it strictly for the educational purposes, and anyone who is going to use it forward should make that note that this is still with ADA. So broadly, the study design was randomized trial. There was a control arm, but it was not blinded. I mean, it was not possible to blind. And it was a random assignment with degludec plus TI and usual care. Now, these short forms I already spoke about. The key is every one of them had CGM. That was a requirement. So the first 17 weeks is the data that we have today. The extension was completed just 1 week before ADA, so that data is not there. In those 17 weeks, first 4 weeks was used to escalate the titration, and I'll explain that in a second. And then the actual effect was studied for 13 weeks thereafter. The number of patients were 123, equally divided, and at the end also you get 57 and 58. The mean BMI, I'm actually blocking my own slide here. Let me see how I can fix it. I can get rid of the participants.
You can move it also.
I can move it.
You can move it, you can minimize
Okay,
it
yeah.
also.
Okay, minimize will be better, I guess. Okay, so age range is they were all adults, though type 1, equal male-female ratio almost. They were not very obese. And the mean A1C was 7.6, but really it was spread over some with less than 7 and somewhere more than 10. These are the delivery methods that were used for the background, which are automated insulin, which is completely closed loop, multiple daily insulin, sensor augmented. And this was a partially closed loop, where the earlier version of the closed loop, where there was a predicted low glucose shutoff, which means only the basal would shut off with hypoglycemia, but it won't give the augmented boluses for high sugar. It was a 19-center trial all over the United States, and one in the Florida was the main center. The target was, minimum 40% were on MDI and 40% on the closed loop, while those who were very well controlled, less than 7, they were not more than 20, just to make it practical point. Older patients, type 1, if it is more than 11, they would not include it. And the baseline insulin requirement was around 20 to 100. They all had CGM. Those who were not included were people were on oral or other non-insulin agents. Everything, those who had a respiratory condition were excluded, pregnant and DKA history, advanced renal failure. So baseline, they were taken in for 14 days. Their baseline was studied. They had their FEV1 A1C measure. They also had the patient-reported outcome with different scores. And then they were randomized to 2 groups. The meal challenge was also used in there. So idea here is they wanted to say this medicine is not inferior to the current injected insulin. So this is basically a non-inferiority trial, which means even if you prove it, it is as good as the current one, it is still a good result. The daily basal dose was titrated first a few days, every 3 to 5 days. And if the fasting is higher, they ramped up the dose. That was before beginning the trial, so that fasting will be well controlled. And the dose of Afrezza, the TI, was based on what patient already had, except that they had to almost double the dose. So if the patient is already on 4 to 5 units of Humalog or Novolog, they will give the 8 units of TI, which means this amount of units you required a lot more than the regular injectable insulin. That's the message. And also you can, because it is quickly in and quickly out, you can give the additional boluses. And because the patient had CGM, they could look at the sugar. And if 1 hour sugar is more than 140, they would give another 4 units of Afrezza. If it is more than 140, then they can give 4 or 8 units based on where the sugar is. So you give the pre-meal bolus, 1 hour, you give another bolus. And then if the pre-meal sugar is also high, you can give another 4 to 8 units in addition to what was patient taking. So basically there is a lot of insulin units. That's what the clinician need to know when they use the inhaled insulin, that it's not unit to unit. And then usual care group had your usual management. And I'm going to skip the baseline slides pretty quickly because we'll discuss the result. Visit schedule was very frequent. Some of them were virtual. And primary outcome, as I said, was checked at 17 weeks. Now, the outcomes measured were, first primary was the A1C. That was tested for non-inferiority. And the secondary measures were time in range, total improvement in time in range, mean glucose, time above range and time below range, along with other parameters. In terms of safety concern, this was the biggest concern raised when you use the inhaled insulin of the rapid onset, that is there any hypoglycemia? Also, these are type 1 patients, so because this insulin goes out quickly, the question of inducing DKA came up. So CGM measured how many times it went low and how many events happened. And the most important, respiratory changes. So measurement of the FEV1 along with pulmonary symptoms. So those were the safety criteria. And baseline characteristics is about 50, 45-year-old, and you can see the other ones. Statistically, there were two groups analyzed. One was intent to treat and other is per protocol. Now the difference is in intent to treat, we include each and every patient who completed the trial, regardless whether they were compliant or not. We see the real life scenario there. And per protocol analysis is a subset of those completed the trial who followed the protocol to the T. So if they are non-adherent or they are deviant from the protocol, they were not included. And then there was a statistical comparison. So quickly talking about the results, it was non-inferior very clearly. Now they looked at this endpoint in a different way, and they found the usual method, whether it is automated delivery, MDI, or partially automated. Today, whatever practice best result that we are getting, even if you replace it with the inhaled insulin, you are gonna not lose anything. So here is the A1C endpoint at 17 weeks with the TI group and usual care group before and after, it remained the same. In the secondary endpoint, when we are looking at number of percent of people less than 7, they were actually more. Those whose A1C was improved also more. And the notable fact is those who worsened there by 0.5 was also high, which means this insulin is not for everybody. There are people who do the same and do better, and there are people who do not do better. And that's why when we combine all the data, we got the no change or non-inferiority. But when you subgroup analyze, you realize that there will be patients who will not improve. Very important clinical point, because that decides whom you want to continue use or not. In terms of hypoglycemia, there was no difference. Percent time below 70 or percent time below 54, both the groups were pretty much similar. So there is no increased hypoglycemia, we can say. And in terms of the CGM matrix, time in range wise, in the TI group as well as usual care group at a different times, there was practically no change. And also please note here that their baseline is only 52% time in the range. So these patients were not greatly controlled as per our standards of CGM, but their A1C was closer to 7.6 average. Now, other outcomes when they use that the patient reported outcomes, PROs with the different scales in terms of distress, confidence, satisfaction, there was no significant difference. Now, in terms of adverse events, anything and everything patient reported was counted. So if you look at the treatment arm, you will find the more adverse events in terms of numbers, the 77%. As far as the severe are concerned, there was only one hypoglycemic case, but that was not related to Afrezza. It was the patient who had too much alcohol previous night. There was no ketoacidosis in both arms. And there are two other serious events in the control arm, but they were again not related with insulin itself. One had appendicectomy and other had a hyperglycemia with ketosis, but no DKA. So chiseling down more in the adverse effect, the key are the cough. So even if the patient has taken the insulin and just did and drank water, that was counted as the irritation or the cough. And also there were some patients who gave some pulmonary symptoms as shortness of breath and wheezing. Those are the adverse events reported. In terms of FEV1, before and after, there was no significant change. In fact, if you look at it, it is only 0.08. So basically 0.1% change was a decrease in the FEV1. Just to make a note that for clinical relevance of FEV1, we need decrease in more than 20%. And that is one of the criteria for discontinuation in the label, that you are required to follow the FEV1. And if there is a drop in more than 15% of FEV1, even if the patient is asymptomatic, you are not supposed to continue. At least in trials, they didn't have any that severe. So simple summary in one line is they had 50% AID users, 93% completed the trial, and primary endpoint met non-inferiority in both the group, intent to treat as well as per protocol. So summary is hypoglycemia metrics also met the non-inferiority criteria. Severe hypoglycemia was not related to the insulin. Other adverse effects are mainly related with pulmonary symptoms, but they were not very serious. Cough is reported in 23%, but it was transient, and no significant difference at FEV1. So what do we take home from this trial? Using inhaled insulin may be good for the patients who are engaged in self-management. It is good who want alternative to the pump or much cheaper than the pump. Maximizing the benefit for T1, we need to repeat inhalation 1 to 3 hours after. So having CGM is kind of required here, or multiple finger sticks. And the clinical care team must understand the rapidity of the onset and the dose differences between the injectable and the inhaled. Now, why would one use the TI? And these are my last few slides. One is some patient would choose instead of injections. Control of the postprandial is better. Now, I did not include the detailed meal challenge here, but the postprandial control was better, obviously, because we were giving extra doses as we go. But as far as pharmacokinetics and pharmacodynamics is concerned, it is rapid in and out. So there is a lower chance of stacking. It is discreet and inconvenient. So we require this to be taken when the food is in front of you. And at that moment, even the restaurant or outside of the home, going back and taking injection versus taking the sniff makes it much easier. And there are no issues of needle phobia or lipodystrophy. But bear in mind, these were type 1 patients. They still had to have one needle with long-acting insulin at least. Reason not to use is patient with the pulmonary diseases and allergic to regular insulin. And pulmonary function deterioration is the one where a decline in more than 20% or the symptoms which appear after taking the insulin. Now, in last 1 minute, 2 minutes, I'm going to just glimpse at the once a week insulin that is on the horizon. It's called icodec. It is made by the Novo Nordisk and brand name is Awiqli. That was pretty nice. Awiqli insulin. So that's why it is spelled like that. Its half-life is huge, like more than 8 days, as opposed to what we can see with degludec 24 and 30 hours, while Lantus is even less. So how they made it stable is they gave the side chain to it that made a very strong albumin binding, but they also had amino acid substitution that made the molecule more stable and decrease the insulin receptor binding. So that way they can increase the life. The European Medicine Agency has recommended for both type 1 and type 2. It's also available in Canada, but in the US, they have, until recently they were considering it, but recently they came up saying do not use it with type 1. And there are many reasons to that. They are still apprehensive about if you give the bigger dose by any chance, you'll have to deal with hypoglycemia for a very long time. It is still under consideration for type 2, and we did not have any data on the, there is a trial that has been completed. It's combined 3. So they have a different trials with combination of icodec and semaglutide. So Icosema is another product by Novo Nordisk where they combine both so that they can have a weekly injection of both. And there are different trials, but these results are not available yet. They just started in 2022. So not yet approved, but it is on the horizon. And I think we completed in time. Thank you.
Thank you, Dr. Ajam, for the lucid lecture. I hand over the session to Uma for the commercial aspect, as well as I cannot see any questions. She must be having access to questions too.
Yes, sir, we've checked. So far, there were no questions. Can I ask the tech team to please play the next video?
iCan, your new continuous glucose monitoring system for all people with diabetes. Easy to apply and comfortable to wear. Real-time glucose monitoring, continuous 3-minute connectivity. Every time iCan. Forget about the unawareness of hypo and hyperglycemia and pain of finger pricks. Forget about interference from vitamin C. Forget about worries about water when you're bathing or even surfing. iCan is water resistant to 8 feet for 2 hours. iCan has a 15-day wear life. With iCan CGM app, you can check your blood glucose anytime and anywhere. With iCan Reach app, you can share your data with loved ones. iCan makes managing diabetes easier so that you can enjoy activities of daily living effortlessly. Set your own alerts for low and high glucose levels. No worries, even at bedtime. iCan provides real-life accuracy. iCan empowers you with self-management. Your choice, iCan. Sanocare, caring for love.
So as there are no questions, I will just ask Dr. Rakesh one question from my side. For the young physicians and for the AI new practicing diabetologist, can you suggest how to begin with the use of AI? From where to begin and
Yeah.
how to proceed?
So I would suggest that you install the ChatGPT app on your mobile. Just log in with your Gmail there. It's a free account that you can create. Don't go for a premium account as of now, because everything which is available in the premium account is also available in the free account, but to a limited extent. So in that, you explore the different the utilities of that ChatGPT. Probably you may not be able to create the GPT as I showed. For that, you might require a premium account. But then you can explore the other GPTs. There are several GPTs which are designed by other people, like the apps we search on the Play Store. The same way you can search for GPTs which can be useful for you. So you just put insulin or diabetes or nutrition, and you will get GPTs which are related to that particular subject. And then they also label how many interactions have happened with that particular GPT. So just like ratings and reviews we see about the apps, here you will see a particular GPT has 100,000 plus messages or 10,000 plus messages. So more the messages a particular GPT has, it means it's used more widely. So that way you can choose some of the GPTs, try them, try for their features, and if you like, and if you want to create your own custom GPT, or if you want to use it more frequently, then go for a premium account. So in the premium account, everything which is coming up will be there. So as I said, the audio visual capabilities of ChatGPT 4o, that is 4 Omni, are there already. They have given good demo of that. And if you see that demo, you will get surprised. Like, that ChatGPT app, you can make it a tutor for your son or daughter. So the mobile sits with your son or daughter. It monitors the kid's tab. It will talk to the kid. It will explain the kid in his own her language. It will answer the queries. So all those things are possible with this. So I think we should start with trying the ChatGPT app first.
I wonder, just curious about the access to the previous lectures. Is it possible? Because I don't think I was formally registered. But is
So I
there a
think
link
it
where
will be
I can
possible.
listen to?
Uma can answer that. Probably we'll have the videos uploaded on YouTube or somewhere. So you will definitely get that access. That I'll find it
Okay,
out.
that would be nice.
Uma, are you there?
Yes, sir. Yes.
Yeah.
Yeah,
So,
we'll ensure that everybody gets access to this, all the speakers.
The link,
Yeah.
perfect.
so Dr. Raju,
Chat-
the study that Dr. Akash, can I ask a question to Dr. Rajana?
Please.
Sure,
So
yeah.
the INHALE-3 study, the data that you presented, it was very interesting. There was one curiosity. I know you may not have the answer to that because you don't have the whole data right now here. The comparator arm actually had too much of the diverse population. There were people who are on MDI and people who are on AID. So the most there is a difference in the outcomes between MDI and AID. There is a lot of difference in that. So
Yeah.
probably we need to look at how the Afrezza, is it doing better than MDI only, or it's better than even AIDs? And also
Yeah.
probably we need to look at the
Sorry,
CGM graphs. Yeah. Mhm.
I have the actual more details. The whole lecture was 1.5 hours.
Okay.
Because I didn't have enough time, I did not include it, but they have broken down this, and what they found is the Afrezza sits in the middle. If you compare with MDI, their control is the
Yeah.
sugars are higher, automated insulin are lower, and more time in range, and Afrezza sits in the middle. So it does better than MDI,
Yeah.
but it is MDI actually by itself. Basically
Yeah,
we are
it's
giving it multiple doses. It doesn't have the loop that gives you the feedback.
Yeah.
So automated is definitely better than that. Like
Right. That's
I'm
what.
talking about closed loop. The one that is partial loop, it doesn't do better than.
Yeah.
Okay.
Right.
It was a data there. Yeah.
So that's what is expected, because it is
Yeah,
expected to
that's
better
what
than-
is expected. Yeah. Yeah, it's a convenience. A lot of people, injectable is not an option. And if it is, I would say, economical,
Mhm.
that's the thing. The Technosphere technology may not be as cheap as insulin, and insulin itself is costlier to begin with.
Right. Again, I know that you cannot compare the doses of inhaled with the sub-Q insulin, but I expect the dosage requirement was more in the inhaled arm compared
Yeah,
to the.
because those units don't make sense, though
Yeah, that doesn't make
they
sense.
are, we are used to compare the insulin to insulin units. Once you gain this Technosphere world, what they found is, and this was very interesting, they did the meal challenge before. And during that study, they kept on titrating the higher and higher doses based on the response. So after spending the time of 13 weeks in the good control, when they did the meal challenge again, now the glucose response was much better.
Oh,
But the baseline, the dose of units used before was much less than units used at the end. So you can actually chase the sugar
right.
much
Right.
safely,
Mhm.
much safely because it is rapidly out. Postprandial, you can give 1 or 2 boluses.
Yeah.
It's just easy to take. That's why. It's a whole different ballgame. I mean, clinician need to get used to that first. And yeah.
Akash, sir?
I think no further questions.
Yeah.
Will the AI be able to predict the at-risk population, the future risk of diabetes, issue sort of customized advices regarding diet and exercise and medications to the patients, or issue precautionary guidelines to the patients? Is a validated AI model available for all these purposes?
Yeah, so all these things, all the things that you listed out, they are all being worked upon, and there are studies showing very good results in terms of prediction of development of diabetes, prediction of complications, and even what else you listed out. All those things are being done, and surprisingly, some things are there which we can't imagine. So there was a study in which they compared only the voice samples of people. And based on voice samples, the AI algorithm can tell whether a person is diabetic or not. Now, we don't expect the voice to be different. There is one study in which they just looked at the chest X-rays. So looking at the chest X-rays, the AI algorithm could differentiate a diabetic from non-diabetic. So basically, because AI has a huge chunk of data and it is a lot more capable than human brain to analyze huge data sets at a time, it has got it has got more, it is more powerful than us, at least in analyzing any kind of data. So definitely prediction models are there. None of them are approved. I don't know whether they'll require approval or not, because these are just like a risk score. We can use it in our own practice. You don't require. It's not a product for intervening in a patient. And then diet charts and all those things, as I showed, there are several studies in which the AI app generated dietary advice, personalized exercise advices were compared, and they were found to be useful. And as I showed in the demo, you can develop your own custom GPT, which can give a diet chart as you like it. If you want it Gujarati, it will give it Gujarati. If you want Gujarati food, it will just include the Gujarati food. So all those things are possible, and they are so open now that any one of us can do it. So you just after the lecture, just download that app and try it. You can do it.
There is a last question to
comment on that
Dr.
Yeah.
Please.
Yeah. So here is a difference between validation and approval. So AI by itself works by validation. So it takes millions of X-rays and associates with the diabetes or not, and it creates its own validation. And there are data that has been presented in these conferences, including our own Shashank has that digital twin data that is a validation of what AI is doing in terms of real clinical picture. Now, Dr. Akash was talking about approval, I believe, whether it has been approved for the clinical use so that you can legally protect it. Because if you are Rakesh is using in his practice, and if there is a question of legality, then it's the question of approval will come, but the validation is inbuilt in AI. Thank you.
Last question is to Dr. Rajaram. Suppose a patient of ICODEC goes into hypoglycemia. How would this situation be basically? Because we have not used it, and you read a lot about the trials and all those things. So, because it is a very
Right.
protected action.
Right. And that's nightmare scenario. And that's one of the precise reason why there is a serious apprehension in FDA of US. The European approval was based on the data that I don't have, or it's not on the web available. But there they did not see a significant amount of this. But if it does happen, somebody accidentally injects, I guess it is going to be a nightmare.
Right.
So I think we are nearing the end of the session. I profusely thank Dr. Rajaram for his excellent talk regarding the inhaled insulin and the trials related to inhaled insulins. I also thank Rakesh for a very, very good talk on the use of AI and the role of AI, which is bound to change the diabetes practice in the coming years. I also thank Dr. Bansi Sabu, Dr. Amit Gupta, Dr. Arvind, and the entire team of Diabetes India for putting through this entire program of learnings from ADA. I also thank RX Events for providing the platform to host this event. I also thank the sponsors, the pharmaceutical companies which are coming ahead to sponsor such excellent CMEs. And I hand over the session to Uma to formally close it.
Thank you, sir. So again, Akash Singh sir has covered it very well. So we cannot thank all those support enough, and not without the committee that has put in so much of time and effort to bringing all these brilliant minds together to make this entire session of 10 days happen. And it's happened with the same rigor and enthusiasm each day. So thank you all for your participation, and have a good time. Thank you.
Thank you.
Thank you, Rakesh.
Thank you, Akash.
Nice meeting you, Dr. Rajan.
Yeah, I'll hope to see you in RSSDI November.
Yeah, do come there.
I will be there. I will there. I will.
Thank you.
Thank you.
जल्दी खत्म हो गया।
टाइम पे खत्म हो।
हाँ, टाइम
लाइव
पे।
स्टॉप कर दिया?
हाँ, लाइव 1 सेकेंड
स्टॉप कर दो।